So here's my the title of my talk today. As said, I'm a specialist in female pelvic medicine and reconstruction. However, in my urology training and advanced training, I did some extra training in neurourology, so in study of neurological conditions that affect the bladder, and this is why I'm here today. I see many patients with Parkinson's disease and other Parkinsonian type symptoms in my clinic routinely. So there's some data from the literature here in this talk, and there's also some practical aspects to treating people with Parkinson's and Parkinson-like symptoms and their bladder conditions. So this is the answer I give when people ask what I do, and I consider myself to be somewhat of the lady plumber of the lower urinary tract. So I just thought that was funny, and my son, who's 5, is really into Lego, so he really liked this slide. So I just thought I'd put that in there. So one thing to start with that is a misconception about incontinence, and incontinence is not a normal part of aging. It is not normal for someone to develop incontinence as they age. And I just want to start with that and to try to normalize the discussion about that incontinence is a problem and is a problem for many people, but it is not normal. People don't just become incontinent because they are elderly. But incontinence and lower urinary tract dysfunction are very, very common. So half of all women and 15% of all men in the general population at some point in their life will have urinary incontinence. So it's very common. So this is a diagram of the bladder, just to familiarize you all with the anatomy. This is a female on the left and a male bladder on the right. They look surprisingly similar, except for the prostate that men have. But there's the body. Oops, pardon me. There's the body of the bladder, the detrusor, which is the large balloon part, and there's the bladder neck, which is the lower part, and then the urethra, which is the part of the bladder where the urine exits, and that's where all the sphincters are that control urination. The bladder itself, however, is a muscle that contributes significantly to problems with the bladder or problems with storage. So the bladder in our bodies has a number of roles that are actually very important, and one thing that it needs to do is to store enough urine. So your bladder needs to be big enough to hold enough urine that you can go about your daily life without having to stop to empty your bladder every 10 minutes. But it also needs to store urine at low pressures, because if pressure builds in the bladder, then it needs to empty, or you can harm your kidneys. It also allows urine to go in one direction. So as urine comes from your kidneys down your ureters, it actually only goes in one direction and does not back up to the kidneys. That's a function of the bladder, which is very helpful. And you don't want your bladder to squeeze at the wrong time, but you want it to squeeze at the right time. So we actually ask quite a bit of our bladders, because it needs to do all of those things to function properly. The nerves or innervation of the bladder is actually very complicated, and I'm not going to give you a big neuroanatomy lecture, but suffice it to say that the pontine micturition center, which is in the brainstem, is the CEO, or the controlling body for all of urination. It controls storage and it controls emptying by very complicated mechanisms. So when people have problems with urination, either leakage or difficulty emptying, you can think about it in simple terms. And one way I like to think about it is that it might be a pump problem, so a bladder problem. It might be a problem with the valve or the sphincter, or it might be the hard wiring or the innervation that are getting mixed up. And it's one or more of those that is the problem. So when the bladder pump isn't working, so the muscle of the bladder isn't working, it might not be squeezing hard enough, which is called a poorly contractile bladder. And this can happen just with weakness of the muscle. With aging, all of us lose some contractility of the bladder, and sometimes it's because the nerves aren't working due to various illnesses such as diabetes or nerve injury. Bladder overactivity or bladder spasms is when the bladder spasms for the wrong reasons, and this can happen with urinary tract infections, if you have a stone or something irritating your bladder, overactive bladder, or when the nerves are not being suppressed properly, such as in Parkinson's disease. The sphincter, which holds the urine in place, can be weak and not work, and this causes you to have incontinence, and that can happen for many reasons, including bearing children, having other neurological conditions, or it can be too tight and not relax properly. And this can be a big problem in Parkinson's because the muscle is too slow to relax and doesn't allow the urine to exit properly. There's also blockage. The most common example are prostate enlargement, benign prostate enlargement, or BPH, which prevents urine from exiting. So if a person can't urinate, it can be the bladder doesn't contract, or the sphincter doesn't relax, or there's blockage. Or maybe it's something going on in the neurological system. And leakage is because the bladder is squeezing for the wrong reasons, or the outlet is weak. Or sometimes, again, it can be a hardwiring problem that the nerves aren't functioning properly and you aren't feeling that you need to go. Or there's something called functional incontinence, where you actually feel the need to go, but it takes you so long to get to the bathroom and you can't make it on time. So that's another reason that many people leak. So let's get on to Parkinson's disease. So urinary incontinence in and of itself is very common. And not just in patients with Parkinson's disease. Again, in Michigan, a study that was done here in Michigan, even amongst younger women between 35 and 64 years of age, a quarter of them report daily urinary leakage. So that's not rare. That's very, very common. And the problem is that it is undiagnosed. So if you ask women privately after they visit their physician whether or not they discussed their incontinence, half of them said they didn't bring it up. Much as Daniela alluded to, many patients have this problem but fail to bring it up because it's embarrassing, they don't want to bother their practitioner, and they just want to keep it quiet. They may be embarrassed themselves. Men also suffer from incontinence very frequently, and this is some studies that were done here in the United States, and you can see that up to 17% of men, depending on age, may suffer from incontinence. So Parkinson's disease, as you all know, is a disease of the substantia nigra, which is the dopamine-producing cells, that is located, you can see right here, right at the top of the pontine micturition center. So it's located very near the urinary control center. The primary symptoms of Parkinson's are tremor, stiffness, bradykinesia or slow movement, and posture coordination and balance problems. But there are secondary symptoms that you're probably all familiar with, and those are constipation, urinary urgency, so that's a very sudden and difficult to postpone urination, urinary frequency, so going often, and erectile dysfunction, which Daniela discussed. And Parkinson's disease is different than multisystem atrophy, which is a similar disease, but that presents differently, in that multisystem atrophy, the bladder and bowel symptoms come long before the Parkinson's symptoms, and that's something that we rule out when we're meeting a patient with Parkinson's and bladder problems. So the symptoms of Parkinson's, which we can call overactive bladder, you can call it whatever you like, it's urgency, going often, sometimes having urge leakage, getting up at night. Those symptoms in Parkinson's tend to go along with the akinetic symptoms. So those are the symptoms of difficulty initiating movement and the motor symptoms. They actually, according to studies of people with Parkinson's, it actually is not correlated with age. So it doesn't necessarily mean because you're getting older, your bladder Parkinson's symptoms are going to get worse. It doesn't matter how long you've had Parkinson's or how much tremor you have. It really goes along with how much akinetic symptoms you have. And again, as I mentioned, the control center of urination is near the substantia nigra, so they're very closely related. So this really explains why people with Parkinson's have more bladder symptoms. But again, it's not just the effects of aging, it is their Parkinson's causing many of their bladder symptoms. So a large number of people with Parkinson's do end up having bladder symptoms, between 38 and 71%. So that's a fair number of people. The most common is urgency and frequency. So those are having to go often and feeling a greater urge. Nocturia, getting up at night more than once, happens in over 60% of people. But this is very common in the general population as well. And urge leakage happens in around a quarter of men and women. And difficulty emptying is more rare, but it can happen in people with Parkinson's that their bladder is weak as well. The medications that are used to treat Parkinson's, levodopa or Sinemet, can make the bladder a little worse, and in some people makes it a little better, but most of the time it actually doesn't change the bladder symptoms. It usually is neutral and doesn't help it one way or the other. So why are lower urinary tract symptoms of urgency and frequency important? Why do we care? Obviously, they're bothersome. They bother people. You have poor quality of life because your bladder bothers you. But people with urgency and frequency are at higher risk of falls because you're rushing to get to the bathroom. You're going to wet yourself. You try to get to the bathroom as quickly as possible and trip and fall. It requires more care if people are having leakage, and it's harder to get out and enjoy yourself, and there's a higher risk of institutionalization or needing to go into a nursing home. So that's obviously not good. And the problems in the bladder add up. Someone with Parkinson's has bladder issues because of their Parkinson's, but all people can develop bladder problems as they age. You may have pre-existing bladder problems from having children or having had prostate surgery, and then add on the problems with movement, and you can have really big problems with incontinence. So all of these things add up. It's never one thing affecting the bladder. It's always a combination of symptoms that conspire against you. So when a patient comes to see myself in clinic who's having problems with their bladder, I start with a history, getting to the bottom of the symptoms and how they present, and do a physical examination of a vaginal exam or a prostate exam in a man. I often do a urinalysis, which is I check the urine for infection because infections can mimic these symptoms quite readily. I often or almost always do an ultrasound residual, so we check to see if the bladder is emptying properly. And this is done with an ultrasound in the clinic, which is a very simple test right after urination. Sometimes I ask patients to do a voiding diary to keep track of what they drink and how often they go. And more rarely, I do more advanced bladder testing like urodynamics or a scope, depending on the situation. But for the most part, I ask people about their symptoms, do a physical exam to rule out other causes of incontinence, and make sure that they're emptying and don't have an infection. So what kinds of incontinence can people have? So stress incontinence has nothing to do with psychosocial stress. It has to do with pressure on the bladder. So this is leakage that is caused by pressure on the bladder. Coughing, sneezing, laughing, lifting, jumping, or running. Those can all cause stress urinary incontinence. Urgency incontinence is leakage that goes along with a sudden urge to urinate. So it's I gotta go, I'm running to the bathroom, and I don't make it on time. Continuous incontinence is actually very rare. It's usually a result of a fistula or a hole between the bladder and some other part of the body. So it's actually quite rare to have continuous incontinence, and people who have this often are totally wet and don't ever urinate on their own. So that's quite rare. Functional incontinence is actually quite common. If someone needs to urinate, knows they need to go, but have a cast on their leg or need crutches or a walker or some other device to help them get to the bathroom on time, they might not make it in time. So that's a big contributor to incontinence in many people. In terms of functional incontinence, preventing functional incontinence and treating it are often the same. So having fluids administered at the same time during the day, managing your fluids in time voiding can often make it around that problem, because if you have a hard time getting to the bathroom, if you plan on going to the bathroom before you need to go, then you may circumvent the problem. Overflow incontinence is another rare form of incontinence. This is when your bladder is full to bursting and you're just leaking a little bit over the top. So it's exactly as described, you're just overflowing. And that's why we would check the bladder to make sure someone is emptying properly. So this is just a quick diagram of what urodynamics are that I use occasionally to diagnose someone with bladder problems. We measure pressure in the rectum, in the bladder, and we do maneuvers. We have a person cough, we fill them to their maximum filling and have them urinate so that we can diagnose what specific problem they have. And this is a tracing that we would get from this, and you can see circled here, that's a bladder spasm. So this person was diagnosed with bladder spasms. Don't worry, I won't quiz you on that. And sometimes we do x-rays to go along with this, and this is just an example of that. So how do we treat incontinence? So preventing incontinence would be great. So timed voiding, going to the bathroom before you have incontinence is a way of preventing incontinence, and encouraging people to have healthy bladder habits in their youth can help prevent incontinence, such as having women do Kegel exercises while they're pregnant and after delivery. All of these things can help prevent incontinence. But by the time someone comes to see me, they usually already have symptoms, so I don't get to do very much prevention. But we always step up treatment in stepwise fashion. We start with conservative treatment, the easy stuff, behavioral management, physical therapy, because these are low risk and can sometimes help people quite significantly. There are also medicines, medical treatment, and there's also surgical treatment for incontinence. So conservative treatment, as I mentioned, time voiding is very, very effective, and I keep coming back to it because it does work very, very well. There's also something called bladder retraining. So if you have a lot of urge and you're going to the bathroom every 15 minutes and it's really cramping your style, which obviously going to the bathroom every 15 minutes would be, training your bladder to hold for just a few more minutes every time will, over time, allow your bladder to expand. Usually people need some medication or other therapy to help them cope with that, but people can retrain their bladders to hold more urine over time. Pelvic floor physical therapy is something I use quite frequently to help people regain control of their pelvic floor muscles. And there's something called the knack maneuver that physical therapists will teach people, as well as urge suppression. And this is just an example of the bladder retraining. So if your bladder is small, you try holding your urine for an extra 15 minutes and empty your bladder on a schedule. If you need to go before your scheduled time, you can try holding it just for a little longer. And I'm not saying hold it for 4 or 5 hours and try to hold it as long as you can. It's holding it just an extra 15 minutes to try to increase your bladder size. So, I'm going to tell you all how to do Kegels right now. So everyone listen. So, there are various ways that people try to do Kegels, and a lot of them are wrong. So in women, this is only directed at the women in the room right now. So when you're doing a Kegel, you are not squeezing your knees together, you're not clenching your butt cheeks, you're not moving your legs in any way. And the best instruction I can give people is you take your labia and you're trying to pick up a marble. So I want everyone to pause and try to pick up a marble. And I want you to hold it for 3 seconds and then slowly let that marble go. Is everyone doing them with me? I'm doing them. Okay. So Kegel exercises are really effective if they're used properly, if they're done at the right time. But I'm not just going to pick on the women. So this is the instruction that you give men to do Kegels. So I want you to try to suck your turtle into its shell. And you all know what I'm talking about. So all the men in the room, I want you to try to suck your turtle into its shell, and you hold for 3 seconds if you can, and then release for 3 seconds. And you're going to repeat that 10 times. I'm not going to do 10 up here, but that's the concept. So the knack maneuver is doing a Kegel at the right time. Half of people with stress incontinence, if they perform that maneuver at the right time, they can actually decrease their incontinence by half. Doing Kegels at stoplights is not going to help you. Practicing and toning those muscles, but using them at exactly the right time is key. The other time that it is key is when you have an urge. So say you are sitting here in the room, I'm talking about your bladder, I said the word leak 300 times, and you're all of a sudden feeling an intense urge to go, and you don't think you're going to make it. So instead of jumping up and running to the bathroom as fast as you can do urge suppression techniques. So you can do 3 long holds of a Kegel while you're having that bladder spasm, and focus intensely on your pelvic floor, 3 knack maneuvers or 3 pelvic floor contractions, and then that urge will decrease. It won't go away. You're not going to be able to hold your urine for another hour, but you may get 15 minutes, you may get 5 minutes, or at least enough time to make it to the bathroom. And one thing that people can't do is suppress urges when they're trying to run to the bathroom. So you really have to focus, stay put, do the urge suppression, and then you can make your way gracefully to the bathroom. Okay? Anyone have any questions about that? Because that's often the part that people are most interested in, the quick fix, the things I can do right now to help. Yes? You contract your pelvic floor just before you're going to do the stress maneuver. So if I'm going to sneeze, I'm going to go, giggles, chew. You can cross your legs too, but it's less effective than actually contracting your pelvic floor. All right, some other things that you can do to help prevent bladder overactivity or bladder irritation. There are certain foods and fluids that can aggravate your bladder, and they may not aggravate your bladder in particular, and if they don't, that's fine. But many people have an aha moment when I tell them that, oh, by the way, caffeine can aggravate an overactive bladder, and they're like, oh my goodness, that's why I have more leakage in the morning. But if it doesn't bother your bladder, it's not something you need to stop. Caffeine does not cause overactive bladder. It aggravates someone who already has an overactive bladder. So it's not because you've consumed these things that you've caused this problem. But alcohol and caffeine are some of the biggest offenders, as are things like spicy foods, acidic foods, and sometimes stimulants like energy drinks. Some patients tell me that things with bubbles in them or aspartame, artificial sweetener, can irritate their bladder. And obviously things like diuretics, like Lasix and hydrochlorothiazide, they make you make a lot of urine, but you can't avoid those because those are to treat your blood pressure. So this is a systematic review that I did with a large study group, and we looked at very in-depth how different consumables can affect the bladder. And there's actually very little data on how things can irritate your bladder. So there was actually some good news about alcohol, that is, if you do engage in the occasional glass of wine. In men, it was actually found that men who consume a moderate amount of alcohol have the least BPH symptoms. So their prostate tends not to grow as quickly if you have a drink or two every day. I thought that was pretty brilliant. The results for overactive bladder were a little bit more inconsistent, but having a moderate amount of alcohol is not harmful to your bladder. Drinking too much, that's not good for your bladder, but having a moderate amount of alcohol is not going to hurt anything. And as I said, alcohol excess or heavy drinking is not good for anybody. Caffeine, even though we do tell people that it irritates their bladder, and many patients tell me it does, there's actually very little evidence, and that there were several articles that studied this, and there was no consistent evidence. So if it doesn't bother your bladder, there's no real evidence that cutting out caffeine is going to have a big difference, but every person is unique. There's very little information on diet and bladder health over the lifetime, but overall, keeping your weight down and eating a healthy diet seem to have a positive impact on your bladder, and that kind of makes sense. And somehow, zinc supplementation caused an increase in prostate growth and an increase in stress incontinence. So something that if you are taking zinc supplementation, maybe to consider, that might not be beneficial. So what about second-line therapy? We've tried Kegel exercises, urge suppression. We're avoiding things that might bother our bladder. There are medical therapies available. So there are multiple medications available. These are just pictures of some of them. There are anticholinergic medications that are there on the left. There's a number of them. There's 7 or 8 different medications that are available. Unfortunately, they all share the side effects of dry mouth, constipation, dry eyes, and they can sometimes aggravate Parkinsonian symptoms and occasionally can cause some memory problems. So these are medications that have to be used with great caution in people who do have Parkinson's. A very new medication that is on the right, which is called mirabegron, it's a beta-3 agonist, and thankfully this has no receptors in the brain, in the bowel, in the salivary glands, so it doesn't have any of those side effects. It can raise blood pressure just a teeny bit, but overall, people tolerate it very, very well, and it's only in people with uncontrolled blood pressure that cannot take it, so it's a medication that I use often. And this is just the side effects for the anticholiners. They can often cause stomach upset as well. And some people cannot take them if you have gastroparesis, which is a stomach emptying problem. If you can't empty your bladder very well, and certain types of glaucoma. So your doctor would go over those risk factors with you. Some examples of anticholinergics are things like ditropan or oxybutynin. This is probably the most side effects of any of the anticholinergics. Unfortunately, it's also the least expensive and covered by most insurance companies. It has the most side effects and is the oldest medication on this list. And it is the worst for brain effects and confusion. So I'm very hesitant to prescribe that for anyone with Parkinson's because it can aggravate those symptoms. Although sometimes if insurance, that's the only thing they cover, we have to go with it, but go very slow and very carefully. Other examples are things like Detrol or tolterodine. This is a medication that's very effective. It's a newer medication, more specific to the bladder and has fewer side effects. Other examples are Nablex, which is also called darifenacin, or Vesicare. There's Sanctura, Tovias. Again, there's a long list, and many of them are very, very similar. So I often go with what insurance will cover because these can be very expensive otherwise. But mirabegron, the beta-3 agonist that I was speaking of, is a very great medication because it has none of those side effects, very mild changes in heart rate and blood pressure. And this is actually my favorite and my first choice in people with Parkinson's symptoms because it doesn't interfere with the other Parkinson's medications as well. Unfortunately, it can be difficult to get it covered by insurance, but it is a really effective medication that people tell me, I wouldn't know I was taking it except my bladder is better, so they're not having those side effects. So in some instances, the medications are not effective. They just simply don't work. We try one, we try another. There's no point in trying all 7 or 8. They're too much the same. It's not worth cycling through and through medications. So, and sometimes people can't tolerate the side effects. The side effects are too great. If your eyes are so dry that you can't wear your contact lenses or you have a hard time seeing, that's not ideal. So there are 3 choices to move on to third-line therapy, and one is called Interstim. There's tibial nerve stimulation, or also called PTNS, and there's Botox therapy. So Interstim is called sacral neuromodulation of the bladder, where an electrode is actually placed in through the sacrum, and this is just a picture of an electrode. You can see it on X-ray. And it works very well for people who have a hard time emptying their bladder, but also for people who have overactivity. This is a surgical procedure done in the operating room in 2 steps. So this is the first step where I'm finding the exact nerve, the S3 nerve root, and placing this electrode. This is what the lead looks like. It's a very small plastic lead, and this is where it's placed near the sacrum. If this works, 2 weeks later, and it's very effective for a person, then we actually implant the stimulator device, and you can see that's an actual stimulator device. It looks very much like a pacemaker. It's not a pacemaker, but that's the best way to describe it. It's a metal canister that gives an electrical stimulation. For urgency incontinence, it works very, very well. In people with just plain urgency incontinence, it's 80% successful, so that's pretty good. And many patients become dry. Patients who are wet become completely dry. The battery does need to be changed approximately every 3 to 5 years, but if it's working, people don't mind having that done. It has been studied in Parkinson's patients. There are a smaller number of patients because it's not been tried in that many, but 4 out of the 6 patients in this study who had Parkinson's, who had an Interstim, had a successful implant. And they did well in the long term, so it didn't fail rapidly. It kept helping them for a longer time. But the disease can progress, and the device could lose effectiveness over time, but we won't know until we study more people. Tibial nerve stimulation is very similar to Interstim in that it's delivering electrical stimulation to the nerves to the bladder, but it's doing it through a temporary means. So this is actually done through an acupuncture needle. So the acupuncture needle is placed right behind the ankle bone into the tibial nerve and connected to a stimulator. And so, the knee bone's connected to the hip bone, it's connected to the spine, and so this actually delivers electrical stimulation all the way to the spine that makes it all the way up to the brain and helps with urge incontinence. So patients bring a book, bring their knitting, whatever they can entertain themselves with for a half hour and come into clinic every week and have electrical stimulation done for 12 weeks and then once a month thereafter. This has been studied in Parkinson's patients, mainly because it's a very popular choice, because it is very easy to do. It's not a complicated procedure. There's no surgery. It's just an acupuncture needle. So in this study with 47 patients, they had improvements in how much their bladder would hold, and they went less often, they had less leakage episodes, and they went less at night. So they went 3 times less at night. So this was obviously a very severely affected group. So it seems to work in that population. And if for some reason it's not working, you just stop it. The one limitation with InterStim that I didn't mention is that MRIs are not possible with the metal device in place, and this is the choice of many people because it's not permanent. It's just an acupuncture needle that's removed before you leave. So this is where the needle is placed right there in the tibial nerve. So this is the technique. It takes a minute or two. You find the nerve and you make a little mark on the ankle. You place the acupuncture needle and you twizzle it in and then connect it to the electrical stimulator. So the last third-line therapy I'm going to discuss is Botox, or onabotulinum toxin, but in this country we just call it Botox. And it has been studied in patients with Parkinson's. So this is done in the office. So a small scope is passed inside the bladder after numbing solution has been placed in the bladder for a half hour, and the wall of the bladder is injected with a tiny needle. And we use a 100-unit dose, which is the lower dose, because we don't want to give too much, because the side effect of Botox can be an inability to urinate. So in this study, they only studied 12 patients, so not very many, but they did do quite well. Most of them responded very well. Most of them did not need to catheterize afterwards, and a few got urinary tract infections because that is the major side effect of the Botox. But they felt that they were moderately or markedly improved. So that's pretty good. Their leaks per day on average went from 3.5 to 1.5. So people are significantly improved. And this was another study that was very similar, that showed very similar results amongst 10 patients with Parkinson's disease. And of those 10 patients, they let them ask at the end of the study if they wanted another injection. And 4 of them actually wanted another injection. The other ones felt that it wasn't worth it for them. So it's not for everybody, but in some patients it can be very helpful. The good news is that it wears off. You do the injection. If it works for you, it can be repeated. If it does not work, it's going to wear off, and then it will be like you had nothing. It's not like having a permanent surgery. It's just an injection. So this is what Botox looks like. All right, my video is playing. So this is a cystoscopy of a bladder. I'm just clearing my bubbles out of my scope. The bladder is a very pale organ, and you can see the blood vessels very clearly through the skin of the bladder because the skin is transparent. And this is magnified, very huge. This is just a couple of millimeter size needle. It's teeny, teeny. So this is me going really, really slow because I knew I was taking a video of this procedure. Usually I can do this procedure in less than 10 seconds, but I just gently make a little puncture in the bladder and inject the material just under the skin of the bladder. And I do it in 10 injections, so it's not one shot, but it is 10 injections over the wall of the bladder, and I avoid those blood vessels to prevent any bleeding. But you can see there's not much bleeding. If there is, it's just a little speck of blood, which would be normal. And because we're putting an instrument in the bladder, it can cause a urinary tract infection. Every patient gets an antibiotic before this procedure. But I do this in the office. Patients don't need an IV. They don't need any oral medication or sedation other than the antibiotics. One question I do get on occasion is regarding deep brain stimulators, and these are an option for some patients with Parkinson's disease. And they have looked at bladder symptoms in patients who get deep brain stimulators, and so they looked at 33 patients who had bladder symptoms and were all getting a deep brain stimulator. Their symptoms improved a little bit. They didn't get any worse, but it didn't have a dramatic impact on the bladder. So unfortunately, deep brain stimulators are currently not the way to go to improve bladder symptoms. So what if we try all of these things and they don't work? Or maybe these things are just not feasible. You don't feel that those are right for you. How are you going to manage your skin? If a person is leaking, skin management and being able to take care of your skin, because when babies have leakage, their urine is different than adult urine. So baby urine on skin does not hurt the skin. Adult urine is very different. It's much more concentrated, it's much more alkali, and it causes more skin breakdown. So adults and babies are not the same when they have leakage. It's very important to try to keep the skin as dry as possible with proper diapering, so something that absorbs the urine and it's not in contact with the skin. There are lots of barrier creams available. Some people use baby ointments like Desitin, and those can work, but there are actual barrier creams that are available that are specifically for adult urinary incontinence. And the one that I like the best is called Calmoseptin, and it's a barrier ointment that actually has some medication in it that soothes the skin. Because when skin gets very raw and very irritated, it's very painful, and then more urine in that area is really, really painful. So breaking that barrier and getting that skin to heal is very important. So what other options are there besides diapering and barrier creams? So for women, there's no easy external device. So there's nothing that women can use to collect urine away from their skin, but men can wear something called a condom catheter. And this is not a catheter that goes in the bladder. I don't really recommend those because they do cause a lot of infections, but a condom catheter is on the outside of the penis and does collect the urine. And this can be much more convenient because it doesn't matter how much incontinence you have. If you don't make it to the bathroom on time, it's all collected in the tubing on your leg discreetly under your pants. So I do have patients who prefer this as a continence mechanism, and there's no odor because it's all contained within the tubing. So that's just an option that I often bring up. So that's it for me. I'm happy to take any questions. Yes?
Does the insurance cover the Botox?
So the question was, does insurance cover Botox? And the answer is yes. Botox 4 years ago was FDA approved for neurogenic bladder treatment. And when something becomes FDA approved, insurance companies have to eventually cover it. So currently every insurance, including Medicaid, Medicare, and all the big insurers cover Botox for neurogenic bladder. Insurance coverage can be a little bit tricky because the drug is very, very expensive. So we actually have a mechanism in our office where we have an insurance specialist. When we book the procedure, she calls your insurance company, she gets it in writing, and then we book your procedure so that they don't zing you with the bill later on. But it is tricky, but it is covered by every insurance. And if a person has tried medication and failed, or tried medication and the side effects were too great, and we document that, then it is covered.
I have the interstem put in, and I'm just wondering, how long should I wait if it doesn't work for me? The interstem?
I guess I'm sorry, I was trying to find you. I see you there now, yes.
I had the interstem put in in June, and I know there's like 21 programs or something that they can do, because none of it seems to work.
So the interstem is a device that has a number of programs available on it, and if one program isn't working, a person can cycle through their 4 programs and turn up and down the stimulation. But if those don't work, the whole device can be reprogrammed in the office. So if you call and make an appointment, we'll schedule for a reprogramming and give you 4 new programs to try to work around it.
I've been doing that.
We do, if a person fails interstim and it just simply doesn't work, it can be removed. And we try to save it as much as possible to avoid a separate surgery, but if it ultimately is not working, then we do remove it.
When would you advise the self-catheterization for a patient?
Self-catheterization I didn't bring up here because that's a small percentage of people with Parkinson's who need to do that. So self-catheterization, we start that when someone is not emptying their bladder completely. It doesn't help with leakage if someone is emptying completely. But if someone has a residual urine, meaning they urinate and there's a lot of urine left in the bladder, and this is causing them problems. So if you're retaining urine and getting infections and having leakage, if the residual is over around 200, we often start catheterization. But there are people who retain urine and it doesn't bother them at all, so there's no magic number that we have to say that you have to start catheterizing afterwards.
So would you say that then those patients are more prone for UTI?
Not necessarily. There are patients who have a residual urine and never get an infection, and starting them on catheterization is not going to help them. But if someone is getting infections, we already know they're having them, so we would tend to recommend they do self-catheterization in those cases.
What about people who have swelling in their legs, which at night then it causes the nocturia? What would you recommend for them?
So swelling in the legs is probably the most common cause of nocturia, and the best way to not have the nocturia is to prevent the swelling in the legs. And one of the most effective ways of doing that is wearing compression stockings. So they're graduated compression stockings, not just tight socks, but medical grade compression stockings put on first thing in the morning, and that prevents all that fluid from building up in the ankles, so that when you go to bed, your ankles are not swollen and there's less fluid to eliminate. I recommend them for lots of people. Pregnant women wear them. I wear them in the operating room every time I operate so that my feet don't get poofy, and a lot of people benefit from them. And now elite athletes have been wearing compression stockings because I guess it makes you run faster to have compression and not have venous pooling. Other things people can do is to put their feet up in the evening, and this isn't just in a lazy boy, this is actually above your head, so laying on the couch with your feet up above your head. But wearing compression stockings is usually more feasible.
Questions?
One over there in the corner.
I understood you to say that the tibial and Botox procedures are less effective in Parkinson's patients who have had DBS.
No, it's just the DBS itself is not effective to treat urinary symptoms. It's just a question I get often. I'm going to have a deep brain stimulator. What's going to happen to my bladder? And my answer is probably nothing. But these don't impact one another.
Would you recommend the condom catheters prior to going into either the tibial or Botox procedures?
The condom catheter is low risk. It can be recommended at any time. I have patients who wear them all the time, and I have patients who just wear them for special events, like they're going to a football game and they know that it's going to be really, really difficult for them to get to the bathroom, so they use it at that time. So that can be recommended at any time.
Prescriptive?
They are a prescription, yes.